that is fine. So we're starting the recording now. So again, welcome. This is Lisa Letourneau with Maine DHHS. This is the third in a series of webinars that we have put together specifically geared towards clinicians, but everybody certainly is welcome on the call today. This is part of our series called Strategies for Addressing Disparate Impacts of COVID-19. And I'm going to turn it to Liana Ames, our Director of Equity and Inclusion for Maine DHHS, and ask her to give a welcome.
So welcome everybody, and thank you for joining us bright and early today for the third in our series of webinars. As Dr. Letourneau shared, our hope in putting together these webinars was to have a means by which providers could collaboratively come together and discuss some real solutions as well, or ideas related to how we begin to reduce the disparities that we're seeing with COVID-19 and the underlying issues that we know have led to such disparities. And so the first of our webinar series, as some of you joined us for that one, focused initially on the voices of community health workers around some of what they were seeing in their communities as they began to support folks around COVID-19. Our second focused on providers and unique ideas that they have shared that they're in their practices that they have found effective in working with communities through this time. And this is our third. We learned from many of you in your questions in our last webinar that there were a lot of questions about what social services were provided by the department and how, as providers, you could help patients and COVID, those coming in for COVID testing, to access such resources. And so today we have Dr. Sharon McDonald and Charles Mugabe from Catholic Charities sharing a little bit about their lessons learned in our social services work related to COVID. I just want to remind folks that we do record these sessions. And then we do have them up on our website for folks who are interested in accessing them after the fact, or if you have colleagues who couldn't be here today, please feel free to reach out to us and we can send you those links. With that, I will turn it over to Lisa and Sharon and Charles.
Great, thanks so much, Liana. And again, welcome to everybody newly joining. So this morning we wanted to continue this discussion about ways to really help providers, and I will always acknowledge my own feelings of inadequacy around this topic as somebody who has been involved in quality improvement in the state of Maine for my pretty much entire career, while talking often about improving quality and access to care, really did not spend a lot of time talking about decreasing inequities and addressing disparities. So I feel like we all have a lot to learn. I think we did learn a lot from our first several webinars. I'm also going to just FYI put a chat to a link. We didn't think to record the first webinar, but the second one, the most recent one, we did. So I'm going to put a link to that recording in the chat in just a minute. But then really pleased today to continue this discussion, talking about one critically important aspect of addressing disparities, particularly around the COVID-19 pandemic right now, and that is identifying and addressing social health needs, particularly of those who are being tested for COVID-19 and or are needing to deal with quarantine or isolation. So to help tee up that topic, I'm really pleased to introduce Dr. Sharon McDonald. Sharon is an epidemiologist and consultant to Maine DHHS around the COVID-19 pandemic, specifically on these issues of building social supports for individuals facing those challenges. In addition, we have Charles Mugabe, who serves as project coordinator for COVID-19 at Catholic Charities of Maine. Catholic Charities, he works there as the community liaison with the state of Maine for ethnically based, community-based organizations, and has been a key partner in these efforts as well. So we're going to turn it over to Sharon. Sharon has a PowerPoint that talks about some of these issues, and then Charles is going to speak with us, and then we're going to open it up for questions. As always, if you have questions, feel free to use the chat function, or then when we're through the presentations from Sharon and Charles, we'll open it up for discussion and you can unmute as well. So with that, Sharon, you are sharing screen and just on the wrong spot right now, but if you go back to your presentation where you were just a minute ago, there we go, yep, okay, yep. And then if you go to the display part of the PowerPoint, we should be all set.
Okay.
Thanks.
I always like to know what's coming, but
However you want to do it, Sharon. We can
Okay.
see it fine.
All right. If you can see it, that's good. It gives me and I can't see Charles. Is he in yet? Okay, good.
Okay.
I am, Sharon, I am.
Okay, good. All right. I intermittently and often turn to Charles, and I didn't want to call on him if he wasn't here. So welcome, everyone. This program for social support was set up really both to address the need to respond to COVID and also to perhaps address racial inequities that had become really obvious in our response with DHHS to the epidemic. Hopefully you all will get an overview of case investigation and contact tracing so that you have a sense of what happens when you see a patient, that will describe where community care or social supports fit in the strategy of COVID response, particularly as a way to address the impact on communities of color and those most affected by the pandemic. We'll demonstrate how to make referrals for clients and patients and to share lessons learned in the next steps. Basically, we can stop the transmission of COVID if we identify cases and their contacts quickly and get them to limit their contacts with other people. Cases should isolate themselves as long as they're infectious for at least 10 days after they become ill. And the Maine CDC works with people to know exactly when that is for their particular situation. Contacts must quarantine for 14 days after their last contact with an infectious person. And community care and social support should be offered to anyone that needs to maintain isolation and quarantine. Now, I want to this is an overview of the sort of steps that happen in contact tracing and case investigation. I'll go in a little closer to those, but basically it starts with up here, and we sometimes refer to contact tracing as the entire realm. So that's diagnosing a patient, it's investigating the patient and contacts, and listing the contacts. So when people talk about contact tracing, they actually mean a lot of different things. So starting up here at the individual community member, do they have, do I need a test? Have I traveled? Should I be in quarantine based on Maine guidelines? That sort of thing. And they might go to a health provider or a testing site, and they will determine the need for testing, offer referral for community care. Can it happen there? And testing site will provide results to the individual. And the laboratory may be doing, it may also go off to the laboratory to provide results. And then if there is a positive case, CDC begins a case investigation. They'll call the individual, explain what to expect. They try to figure out how did the person become infected, and also if the individual has symptoms, if there's something to worry about, and make a list of who are the people that they had contact with that may meet the criteria for close contacts. And they determine the end isolation or the end isolation date. With that list of contacts, that is transmitted to the contact tracing team to be entered in a SARA alert, which is the system which tracks contacts. They will call the contacts, find out if they're symptomatic, what symptoms, they'll enroll them in the SARA alert, and then find out, explain the quarantine and settle on a end quarantine date, and which will change over time if the person doesn't maintain quarantine or in fact has trouble with symptoms. And then the step here is any one of the steps above can refer a person for community care or social support. And so this is a flyer we make available. It's on our website, but I just wanted to go over those steps. So what's been happening in Maine to date? We had our first case on March 12th. There have been 4,918 cases as of the 13th of September, 432 hospitalized, 137 deaths. That's really remarkable in many ways, both for what an amazing pandemic this is, but also how well Maine has managed in this. However, on these, up only 1.4% of the population represent any from 18 to 22% of the cases at any point, 10% of hospitalizations, and about 3% of deaths. So much greater than it would be equitable. The Hispanic or Latinx make up 4% of all cases, 2.6% of hospitalizations, and so far, luckily, none of the deaths. So in Maine DHS began offering community care and social support services for isolation and quarantine in June of 2020. it began with a first round of funding to kind of quickly make sure that as case investigators and contact tracers were talking to people, that we could in fact quickly have a social service response community care. The first round of funding went to 10 community action programs out all through Maine, several areas, and included Catholic Charities and Wabanaki Public Health, so that people could in fact be dealing with people of all cultures and link with the social service response. A second round of funding was announced in August and is being worked out now in September and October that emphasizes disparities. And the core services are available to all Mainers. I'm going to list them on the next two slides. And there are two types of social services. One is the community level social services, such as social mobilization, outreach, I want to say ethnographic responses back, but also then the individual social services that are used for patients and clients as they are determined to need to be in quarantine or isolation. So this is the first list of first list of services. And we have cultural brokering and interpretation, housing to assure safe quarantine and isolation for patients or contacts to safely stay home and prevent transmission of the virus, transport to doctor's appointments, to housing such as shelters or for testing, food security and support to assure food is available for all persons in isolation and quarantine. Health prevention activities and medical referral is available for cases and contacts. And that can be things like a mask, thermometers, sometimes getting to doctor's appointments, getting for testing, that thing. Psychosocial care, psychological support, and emotional first aid. This links with the Strengthen Me program and with other mental health and just general resilience efforts in some of the programs. Then for those eligible, the social services will ask people if they need income support during isolation and quarantine, provide case management. They will also provide a link to other ongoing case management. So we hope, what we found is that many people enter this system, they've never been in contact with social services, and in fact, maybe they leave with a better sense of what's available in their community for what they need. And then these are services at the level that many of our new partners are doing, such as risk communication, messaging to protect families and society in general, ethnographic assessment, getting word back about what is going on in the community in terms of beliefs about testing, the disease, so that the messaging is in fact targeted towards misconceptions or actual conception, right ideas, but that need to be communicated. And then partnering agencies. So how referrals happen, I just want to say it's very easy. And basically you send an email to this address, which we'll give many times, is on our flyers and is on our website. And we monitor that site all times between 7 a.m. and 7 p.m. every day of the week. There are also, just yesterday, we put up a link on our website to a form that can be filled out automatically. And we'll be testing it out to be sure, but this will get you there. And the agencies and cultural brokers, all the services promise to be available within 4 hours or certainly the next day. Sometimes people say call the next day, that sort of thing. So we try to be very responsive. This is not a dead letter box. So I want to turn to Charles a bit and talk about what happens when a referral is made.
Thank you very much, Sharon. So my name is Charles Mugabe, and I work with Catholic Charities, and I've been basically the liaison between the state and all community-based organizations all over Maine. And I won't go much into details, rather proceed from where Sharon has talked, because she's explained a lot in terms of what exactly we've been doing. So when the referral comes to CDC, she's explained the entire process, especially when you send the full names of the individual, the address, the phone numbers that's needed. Right after then, the plan is to send the particular individual to a particular community-based organization. So the purpose of understanding this is in a sense that, as a background of this work, we had the funding from the state that enabled multiple contract and subcontract with a lot of individuals, with a lot of organizations, in a sense that we were lucky to partner up with more than 20 community-based organizations who serve particular regions, particular communities, and have capacity to do all the work that is required for somebody who is going to quarantine. So once we get the referral, what we do is we send that person's name to our particular community-based organizations that sort of that falls under the community to where that person belongs. And what does that what is a part of that work? How does it look like? So the important thing is the cultural brokering piece, which the community-based organization has to ensure that this person understands what quarantine means, what isolation means, what exactly is going on, because we all know that this COVID-19 has hit everybody hard, especially within immigrant communities, and it's an absolutely new thing to everybody. So when we're talking about cultural brokering, what is that? So the cultural brokering is the action whereby somebody with both experience, right? I would say a community-based experience and a Western experience is acting as an intermediate, as a communication mean between a new Mainer or a community member with a provider. And we've realized that that is absolutely necessary right now, just because of the fact that this is COVID-19 is absolutely new. People are not aware of what is happening out there, and the cultural brokering piece sort of helps connect community members to the providers, community members to social services. So that's where cultural brokering comes in right away. So after a referral comes in, we make sure a cultural broker is in between the CDC and the community individual to make sure that the person understands all the information CDC gave them, and also do a thorough assessment of what they need. Because when services are being offered, like Sharon mentioned earlier, there are people that sort of resist to give out, they don't feel at ease to discuss about what they need. And sometimes they're concerned about their immigration status. At some point, they're concerned that this could backfire on them later, whereby they could have to pay back later. Some of them are concerned about the public charge policy that came in a while back, whereby whoever is accessing any federal or statewide benefits, they are not eligible to bring their families to the United States, or to reunite with their families, or to get green card, or even to get citizenship. So such kind of threat sort of makes people afraid of getting any help, and that's what we've been seeing. So that cultural brokering part there, the cultural brokers themselves are trained and equipped with precise information, so they're not rumbling in front of a client, but rather giving them precise answers to be like, well, this benefit is absolutely free. Nothing is required in terms of your immigration status, and you don't have to worry because you're not going to pay back. This is just to support you, to make sure your quarantine goes in well. So basically, that's what happens. And after we get all those assessments from the individuals, we get their needs, there are many partners who are absolutely equipped to provide those needs in hand. And we've provided to many families, and I think Sharon was able to share the data earlier, whereby we've served a lot of families. So basically, that is what the process looks like within community care. I would say there's a lot going on in terms of the cultural brokering piece itself. In addition to that, all community partners who serve specific communities, that helps us a lot in sense of being sure that this person who's being referred is being served by their own people. If it's going to, let's say, Congolese community, if the person belongs within the Congolese community, we have partnership with Congolese community themselves, with Angolan community, Rwandan, Burundi, so on and so forth, that can serve people with all culturally appropriate need, So from our side, we're not worried that, well, this person could be getting help from a white-led organization. I'm sorry, but we are sure that this person is getting appropriate support, and the folks providing the support are well equipped and funded to do the support. So the referrals after it leaves CDC or DHHS is to make sure the person is getting all culturally appropriate need and is well oriented in terms of what is happening. Thank you.
Great. So I'll go back. So the reasons that you might refer are really any reason based on your judgment, whether it's the investigators, enrollers, school nurses, the clients themselves, and community leaders, such as Charles is talking about, that they believe that the person is going, or the family is going to have trouble maintaining isolation and quarantine. It might be that they have difficulty understanding the instructions, or that there's multiple people in the home and that's going to be very hard. So, you know, the default is if you have a question, go ahead and refer. When you make a referral, this is the information that we'll be asking. The name, who is it that's making the referral, the name of the client. I put a little asterisk beside the things that really help us make a tailored referral. We need to know what town they're in for sure, phone number to reach essential. I don't need to know, but it's nice sometimes to know if they're symptomatic, if they're a case or contact. What their primary language is very important. The reason for the referral, such as you know at that point, it will always change as they talk to other people, and that's perfectly fine. We ask that when you're talking to a patient or a client, that you ask permission to share this information so that they know with a local social service or community care organization. I like to know the number of people in the household because, in fact, if you bring food to someone, those common things requested, we don't want to bring it for just the client. We'll bring it for the whole family. And is this same day need or can it wait? So we have the state email that you can use. I realize I haven't put in the web form yet as of yesterday, but I'll update that. So this is an example. This is an example of something that came from Maine CDC or could come from a community leader. Gives the man's name here. I've made these names up. Tested positive in the emergency room. He's mildly symptomatic. Lives with his family and 3 children. His wife. This is his phone number. This is his address. He's an Arabic-speaking man from Sudan who's Black. He expresses concern about food and provisions for his family. And he gave permission to share his contact information for social support. And if, in this case, they thought the anticipated date of quarantine. And that's important for us mostly to know, are we talking about 2 weeks of food, 2 days of food, because some of the time frame. When a cultural broker or somebody calls the client, then they will find out more issues that have not been named before. So that's all the information that you need to send. I want to clarify, particularly in working with us, social service agencies and health workers, that they've got to the point where with HIPAA, they're really afraid to share any information. But this is a public health emergency. And under HIPAA rules and public health law, in fact, you can share information in a different way to protect the health of the public. So HIPAA privacy rules that healthcare providers and insurers may disclose information about patients without their authorization to the Maine DHHS and CDC for the purpose of preventing or controlling disease. And then we get the verbal permission from the client once they've been in touch, as you've talked to them or the CDC has, that they can then, if they agree that a social service agency will reach out to them. So you can send it by email. It's just different. It's somewhat less stringent than you are used to. We take great care with it, but that allows people to move quickly to protect people from being in contact with each other. I have at the bottom of the slide links to the public health law as well as the HIPAA rules. So what have we done so far? From June 10th, which is when we stood up this operation, to last Friday, 13 weeks, we've had 302 separate referrals covering either through events or households, 631 Mainers. We get on an average 15 to 20 referrals per week. That's actually going up recently. We've had 155 people that were provided shelter in quarantine or isolation, and that can be in Bangor, South Portland, Sometimes there was one up in a rustic for a while to deal with folks. So it really varies. Maine State Housing and DHHS will put together quarantine shelters as needed if it turns out something's going on. Primary reasons have been for referral are food, shopping, and then culturally appropriate food. And in that case, sometimes the local agency, social service agencies will work with the person. They'll make a shopping list because when CDC or when you say to them, you gotta stay home, they can't even go pick up their medicines. They can't go shopping. So the agency will call them up and say, what do you need? We can get it. And they'll go to the African markets. They'll go anywhere. Sometimes if they're in shelter, they'll bring hot food or cooked food, which has been arranged through different communities and people like that to make sure that they're don't feel punished and they in fact can sit, whether it's in the shelter. You need to know that a shelter is a hotel room. It's not, many of us when we picture a shelter, we're picturing something different. This is a hotel room in some part of Maine. That's food is the biggest request. And the second is really cultural brokering and language support. And within Maine, anywhere on a weekly basis, anywhere from 3 to 14% of the cases or contacts are non-native English speakers. But for those that are referred for social services, over 60% are non-native English speakers. So we use Charles and the many community agencies to work with people to help explain what's going on and provide support. Also, these communities are much more likely to be affected. They are in workplaces, they're essential workers, and so it's not surprising that they are in fact much more affected. Okay. So other reasons for referral have been rent assistance, income support, diapers, thermometers. There are a multitude of varied requests, and I want to say that I'm new kind of to the social service. I'm a medical epidemiologist, and I have just gained the deepest respect for people that work in social service. They are wily and scrappy, and if you think we don't have much of a health system, you should see what we have for a social service system. And these people can navigate the fragments and really deliver. The geographic distribution of COVID referrals for our community care in Maine has primarily, Cumberland, of those many referrals, the majority have been in Cumberland. Hancock County, which you might think, what's out there? And in fact, these are farm workers that came. That many were waiting for their isolation and quarantine, but some were tested, had come from out of state and needed to be quarantined for a bit. I will say that the employers to date have been very good about paying sick leave while people are in quarantine, and it's pretty admirable. York County, 27, and 24, Scott 10, Aroostook, Oxford. So you can see, and then we get down to some counties where, and these are just referrals. These are not cases. These are referrals for social services and kind of the broad depth of range of all the different agencies and where they've reached out. What have we learned so far in this fast-moving operation? First is really that we need to incorporate cultural brokering, interpretation, and translation in as early as possible. The case investigation process is, as someone said, invasive. It is asking, it's all in your business. It's asking, where have you been, your symptoms, it's going into depth, and then tell us the names of everybody you've had contact with and their phone number. It's not a conversation that you really want to be having, and it's bad news. So to some extent, you want that to be done in a sensitive way, which and certainly the Maine CDC tries to do. On the other hand, they have a particular goal. So the extent to which they incorporate cultural brokers, or that you as a physician, for example, in the emergency room, within a pretty short notice, Charles and the other agencies can get folks to talk and reach out to clients. So you can have a client that's suspect, waiting for testing, and we will respond to that. They don't have to be a formal case. That's really the big news that I want the physicians and their social workers to know, is that we'll provide services to anybody who's affected by COVID. Communities are prepared to provide services to their members, and they've been doing so, and it's been a big source of frustration to many of them as they got called, the Somali community, Congolese community, Cambodian, that they were already being asked by their community members to provide services and help them manage unemployment while they're sitting in quarantine and that sort of thing. And so they were been doing that. And so the response of DHHS, and by the, I would say, the admirable advocacy of the community to really say we should be full partners at this table, funding in phase 2 and through phase 1 in subcontracts, Catholic Charities, Opportunity Alliance, York County, Community Concepts have in fact been doing that. So I'll show you the list of agencies that we have as partners at this point. Then developing partnerships between those agencies and communities on the ground. So that's been, this works better when we do these things. We want to really to inform people and engage them. When we find out why people left quarantine, it's things like, I needed food, I needed work, I needed cigarettes, all the reasons. So we're trying to really get very early to reassure them and bring them things, that sort of thing. So you as providers can, whenever you find, you can send it to the email address, and we will have the web link in which you can, you or your social case managers can fill those out. Working with employers has been a very big deal. There are a few notable outbreaks with farm workers and other workplaces. We're getting people in right away to work with the whole group. And I think this may become an issue with schools too, as there are cases and people begin to become frightened and nervous about the ways these things work, that will be important. Community leaders in particular, because people are going to their community, they say, I've got this positive test, what do I do? Can you help me? I don't want to talk to the state, that there can be a discussion so that they can participate in the case counts and this public health strategy, but be reassured that they won't be penalized for doing any of that. And then the CDC investigators and contact tracers, to them it was a great relief to have services available so that when they were having these hard conversations, things would be that they knew they could offer something. It's important to get on the ground quickly to be sure that as these events happen, that we can be there, and particularly with cultural brokers and folks that can help them understand what on earth is happening, and again, to not feel like it's a punishment. With the phase 2 funding, and particularly at the behest of many of the community organizations, we want to move towards prevention, social mobilization, and expand testing. And so it's considered a social service in the sense that many of these organizations with community health workers and outreach workers of all sorts will then be going door to door, doing phone outreach, passing out flyers, encouraging people to come for testing at sites, that sort of thing, so that we get on the front end a little more than just waiting for people to turn up positive or be worried. So in summary, we are asking people to stay home for 10 to 14 days at least, and sometimes that can get up to 20 or 24 days in the worst case scenarios for isolation and quarantine, and that is a huge ask. We want to make that possible. We want to make it as fun as possible and without stigma. Community care and social support is easy to get, quick to receive. We will be really working in ours to keep doing outreach like this, reaching to school nurses, to translators, to everyone, to kind of let them know that it's available so that they can quickly kind of provide those services. And again, for physicians in particular, there was frustration early on about suspect cases, patients under investigation, people awaiting testing. All those can be provided social service and then when we find out, for example, if they're negative and it's fine, then we'll withdraw. It's not a problem. And that we really want to demonstrate an understanding of racial ethnic disparities and provide support with more community organizations in the planning and response of this. And we'll be broadened, as we broaden to include partners to assure that most impacted people are not isolated or hurt by the epidemic. So this is just sort of my contact. I really want to acknowledge, I can't acknowledge everyone that's been helpful. This is a team within DHHS that I work with, but it includes certainly an enormous number of people out in the community as well, people that have provided information to us. These are our phase 1 contracts with the CAP agencies, and they basically, and this includes Wabanaki and Public Health, Catholic Charities of Maine. They were provided money, and we at that time, all of us just said, we need to make sure there's social services available to people. Here's a core list of those services, run. And they got money that was, nobody knew how many cases they'd have. They really jumped off the deep end with everyone. They also began, a couple of the particularly Catholic charities, Opportunity Alliance and others, began to reach out to the communities most affected and work with them. So the subcontracts and phase 2 contracts, here includes more of our partners. And then these phase 2 partners that weren't covered here in phase 1, additional lists. So I think the fun part, we have an arts organization that will be doing kinds of outreach and messaging, as well as public radio, that sort of thing, to make sure that social mobilization in the front end. So I just, public health and prevention for COVID. COVID's a social disease. Its cause is social and its cure is social. And so think of the social services because it has a huge impact on people's lives. So I'm going to stop there to give people a chance for questions, to talk to Charles and to me. And Charles, you may have something you'd like to say from this point.
Thank you, Sharon. I think you covered a lot of other parts of the social services. I just truly do want to encourage folks to make those referrals, because these are things that, our community members need while they're in quarantine, and it is absolutely available to everybody, not only folks of color, but everyone anywhere in Maine. So the service is wide, and you can absolutely make the referrals, and you have to be reassured that most of the folks that will be providing services are equipped and ready to do the work. They're just waiting for people to work with. Thank you.
We yesterday had a meeting with a group, one of the groups, and we were asking them about their experience to sort of reflect to you all. And they said, you wouldn't believe the gratitude that people have when you drop groceries at their house, or suddenly you help them solve one of these problems. And that in fact, people, when they'd been talking to the case investigators, it just sounded like a disaster and they're so upset. But then in fact, in working with them a bit, they in fact cheered up and were very touched by this. So that's the good news.
Sharon, there's a couple of questions in the chat. I don't know if you can see them.
Hang on, let's see what I can see.
We could, it's kind of, a lot of people put their emails, so we might want to just sort out the questions and read them because they're sort of buried.
Sure. One of the questions was about availability of some of these handouts in other languages, as well as whether about tribal engagement in some of the social services.
Yeah, these 2 handouts that I've sort of shown here, and I have a couple of, we have others. They're available in many languages, and Maine Med Center has just made some videos that will be available for practices for people that are before testing, that have gotten positive test results back. I know that Catholic Charities in Zahara has done quite a bit, as well as Maine. That is a organization that's training community health workers. So just about everything. Leanna, you know the website better in terms of where people might go to get some of these materials, and anything that we have, we're also willing to translate if it's not already.
Great. And Leanna, this is Lisa. If you want to in the chat, I was just looking for the one with the videos from Maine Med. I haven't found that yet, but if you want to put any links in there, just read out another question here. And I had also chatted in, and there's a lot of chats there. I'm not sure if people can see it easily, but the email, just one more time, is DHHS, am I saying this right, Sharon? DHHS.covidsocialsupport@maine.gov.
And we will, in fact, for anybody who uses Aunt Bertha through Maine Health, there will be a link through there. And really, literally, I think tonight or tomorrow, the fillable form, so that you don't even have to remember the various information that we need. You can fill out the form and it will automatically come to us.
Great. And then specifically, are the tribes, Native Americans, Native Indigenous, involved?
Yeah, that Wabanaki Public Health, their activities that Wabanaki Public Health has done about this has been quite comprehensive and holistic, and their prevention activities, the ways in which they've done outreach to tribes, and the response to actually a small number of cases that they've had has been really admirable. They, pretty much have our biggest thing is to be sure that cases that are found out by CDC are transferred, and that Wabanaki Public Health knows about it, so that the right social service agency is given a chance. The Wabanaki Public Health knows, in fact, Indigenous population.
Great. There's also a general question about, will the slides be shared? Yes, we will definitely do that. We've also, again, we're recording, so we'll post that right now. The recording from the last webinar is posted to the CDC website. So I will put the link for that, because we will put this one there as well. I don't know that we've actually posted the slides before, but we will figure out a way to do that.
Yeah, in fact, I'd love people to, they're absolutely available to folks, because, creating quickly and putting things together, and I keep changing them for things. So we had a chance to update them in the last few days to prepare for this. So they'll definitely be available. You can even ask the social support website. We get a certain number of things into our email box for social support that are just questions, or in fact, clients that have questions that are, I'm coming from Africa and I'm coming to Maine, and I need to, if CDC answer some of those things, we can do that and reach out to folks as well.
Great. Then there's one, do you work with people who are COVID positive and live in a residential home?
Yes, and I think, Lisa, you probably know some of those. Sometimes, a couple of times, residential homes, they've had to separate different kinds of group homes, and some of the clients will need to go into the quarantine shelter. And so the client and maybe the staff will both go stay in the quarantine shelter to help provide those services, depending on where that is. And then we make sure that there's enough to entertain somebody sitting in a hotel room, and then food to make it tolerable to be there. But our biggest problem is really transport. That's what we've been struggling with, to make sure that there's safe driving, that drivers can get people across Maine, and we are working on that. But people with mental health illnesses, all sorts of people have been in shelters, and we try to make sure that there's enough there for them to be safe. Yeah.
Great. There's a question about, have many of the cases served been in a situation where the children were the positive case?
Yeah, well, yes. And what tends to happen is that the parents are, not willing to leave the child, understandably. And so either we have not had children in the shelter with we have, I take that back. We have had a child in a shelter with a parent. Parent might be the contact, and that means the parent's in for a bit longer of a total time for quarantine. Most folks want to stay at home, and the whole family goes through it together. But we take themselves into a shelter, so they have to have somebody with them. That there are guidelines by CDC where they will, in fact, how to help people if they're trying to reduce exposure in the home, and how to do that. It is, it's hard, but it is doable if you have a house that's set up for it. And a lot of folks, are housing's too tight to allow that.
Okay, there's a more general question. Are there statistics for folks impacted who live with disabilities? And I'm not sure if you mean statistics about people impacted with COVID. I don't believe CDC is able to track it quite to that. I don't know if maybe the question, Sharon or Charles, is around social services for folks with COVID and disabilities.
We have not, we don't have that. Yeah, I think that we don't track that.
Yeah, okay. Then a couple questions from our new Medicaid Medical Director, Fran Jensen. Why don't you wave and say hello to everyone? Thrilled to have Fran on board, newly on board this week. So have there been many evictions? What are services available to make sure Mainers aren't evicted? And then there was an earlier question, I don't want to lose track of that, Fran, about that I'll get back to in just a minute. We'll stay with this one for a minute. Evictions.
We are hearing about the fear of it, and Charles may know better than I am, but than I do. We're hearing about the fear of it, and folks are very concerned that they may, be on the edge of that. But I haven't been hearing about a lot of evictions. Charles, have you heard much?
Yeah, well, here and there, Sharon, not really a lot, because in most cases it's possible to reason with the landlords, and we've done that. They've acknowledged the situation of quarantine and not working, and be lenient a little bit. But we've seen situations whereby after the 2 weeks of quarantine, the landlord is like, "You have to pay me. You're supposed to be working now." So in those situations, there are partners who already have some sort of funding source that they're giving out. And the partners that we have right now working on social services, most of them are case managers as well. So as part of that case management, they do the outreach to connect those families with the funding sources that are able to supply them in order to pay rent and avoid eviction. Yeah.
And we would much rather help them pay their rent than put 4 people in a shelter even if it's a hotel. So the services can cover keeping them in their home. It does not cover, a long period of time. It's usually 2 to 4 weeks that they are given at least rent assistance to cover that period of time.
I believe there have been some federal and state rules prohibiting evictions up until just now, right? I think there's something ending.
Yeah,
right
Lisa,
around now.
there is, this is Christine Jenkins, the district liaison for Maine CDC for Cumberland District. And there was Governor Mills' executive order on April 16th to limit evictions and protect housing.
But it's ending now or soon, Christine, right? The people are fearing it's going to explode because something's ending, right?
Yeah, I'm looking at this, I'm reading the executive order right now. Actually, I can put the link. Maybe I can put the link in the chat. I'll try to do that. But I don't see the date for it to end, but I'll do a little research.
And I might be misquoted. That might be a federal thing that's ending. So don't overinterpret that. But I've seen a lot of angst about some protection against that's coming up against a deadline. So, all right. And then Fran had earlier asked what systems might be in place to continue this kind of support after this phase of the pandemic or for future pandemics. And that's probably a bigger policy systems question, but any thoughts about that, Sharon, Charles, or otherwise?
Well, I think we're all worried. The CARES Act funding has a hard end date of the 30th of December, and Maine has to get all the invoices in to the federal government by that date. So some of our services are on, at the mid to end of November have to stop to get all of the invoices in. So we're, advocating and worried that in fact, the congressional action and other action needed to be taken won't be available. I mean, as an example, we're worried wreath workers, the wreath worker industry goes through the middle of December with migrant workers and farm workers. And so the agencies working with them are aware that they may be moving to private funding if there's any gap there. So everybody's got that in the back of their mind. You have to work very fast and with a lot of uncertainty. I think that I've been very disappointed that this sort of, these dates, we're hoping the funds will roll over and that additional funding will be provided, because really, managing this without social supports it's very difficult. I will say that it is amazing as part of a collaborative, a national collaborative. There are an awful lot of places such as Atlanta or Los Angeles that don't provide any social services at all. And that really hinders the willingness of people to participate in the public health strategy and that kind of thing. Yeah.
I mean, I would only say that, the partnership that we've created is very strong, because in the beginning, everyone was doing their own thing, but now we've all come together to truly respond to this need and be part of this effort. And I see that even, this COVID will certainly continue, but if there is any funding coming in later, even next year, it will be a lot easier to regroup and continue with the work just because of the partnership and relationship we've built as of now. So that is the only thing I would add. Yeah, thank you.
Great. I think, Fran, you were going to make a comment. Thank you for putting that chat in.
I just want to say that Los Angeles actually does now have a system, and And I just know that because I worked with someone here who, through Baltimore City's COVID hotel, as we called it, and the director of that went out to Los Angeles. So if it's okay with you, I would like to share this information with him so he can ramp it up there so we can get more evidence across the board from a federal perspective, perhaps, to keep the momentum going so that, again, to echo my point, and you're all about sustainability, I think it's super important that we put in systems to continue this work. So it's not just a one-off. And actually the Surgeon General came and visited. So I think there is momentum. So let's continue to beat that drum. I'm happy to help in any way I can to do that.
And it really underscores what we've
Yeah.
known about spending in the U.S.
Right.
healthcare system for years, right? That we do worse with more healthcare spending and less social support spending. This is magnifying and uncovering what we know is a chronic problem with our system of care. So,
Okay.
and then you also chatted, Fran, it was
Of
the
course.
federal CDC put
Yeah.
a moratorium on evictions. Not sure about their authority. I think that's what I was recalling. So thank you for that.
Yeah.
One
There's
of the take-home messages I want to include is that, this is really the test of local public health for many places. And there may be some advantages to being able to do a state response and have certain things centralized. But by and large, I hope we walk out of this also with local public health that connects social services with clinical services with public health services. And not having that, we have the districts, and that's a big job for them. And they have, in many of the towns, mine included, a lot of the public health authority for town health officers was downgraded, just a lot fewer people. And I hope we kind of give a boost to some of that as well.
Yeah, certainly lots of discussions going there. And speaking of that, though, I wonder, Christine, can you, or if there's other public health district liaisons, could you unmute and just say a little bit about yourselves? Because I think that's another great resource for folks around the state to understand that they are located within a public health district. There is a public health district liaison. So could you just say a little bit about that, Christine? I don't know.
Yes, I'm happy to. First of all, it's just great to hear the work that you're all doing. We were aware of it, but to get the details is very helpful and inspiring. So my name is Christine Jenkins. I am the district liaison for Cumberland District, which covers all of Cumberland County. We have 8 public health districts across the state. Each one has a district liaison, and we also have a tribal liaison, which is demographically defined. Most of the districts are multiple county districts, with the exception of Cumberland, York, and oh gosh.
Scott, I think.
Aroostook. Gosh, I lost my A. Aroostook. Sorry. So those are all single district public health districts, and we act as a connection between Maine CDC and our local communities. We all live and work in the communities that we serve. And we identify gaps. We put people in touch with other agencies or services when they need them. We work together with the healthcare providers, with the towns. The local health officers were mentioned. Each of the district liaisons is responsible for connecting with the local health officer and making sure that they're aware of any health issues that are maybe of concern to their particular area. We also serve as a resource to them. So we are in very close contact with them. And when they have any kind of problem, they'll call us. We do a lot of constituent services. During COVID-19, we've been doing a lot of organizing meetings. We've been serving as contact tracers and case investigators. Really the on-the-ground presence for Maine CDC and reporting directly back to the director and connecting with EPIs and any community partners. So we're working with the shelters, we're working with schools, we're working with the group homes when they have outbreaks, long-term care facilities. We've been working on getting personal protective equipment to people, making sure they have respiratory protective programs in place if they're going to be using N95s, making sure they're getting fitted for N95. So it's a whole long list of things that we do. But basically we're were the connection for Maine CDC at the local level.
Great, thank you. And I just put in a link in the chat box. Oops, wrong one. I had to put it wrong, everybody. To website with public health district information and the liaison information, so that the Christines in each public health district, if folks don't know who your district liaison is, can be a helpful connection along these lines as well. There was a question about funding. Where did I see that one? Sorry, there's a lot of things in the chat. There was a question about connection to you have more information, links to those funding agencies. I'm not sure, Rachel Huddleston, if you want to unmute. I'm not sure what the reference was there.
Yeah, I think it was just what Charles was mentioning, like if there was an eviction issue or anything to get that funding. I didn't know if you guys had more information on those links or like agencies.
Yeah, thank you. So one of our partners, Mono and Mono, in the Down East area, they have a funding source that was raised through donations, hundred of thousands of dollars and plus that they've been distributing to community members in urgent need of funding just to avoid eviction. And so far, that has been one of our most reliable source. But other than that, the Maine Housing, they're also having their own. There was some of the funding that was dispersed as of late, up to $1,000 that was supposed to go to families, and the application is through the Opportunity Alliance that we've also used for a while. And there are municipal funds, especially in the Portland area and Lewiston, that providers can access in order to support their community members in order to avoid eviction. So there are a couple of fundings, but if you want more resources or if you want the links, you can. I can put my email in the chat and feel free to email me right away. I can share the resource we have and the resources we've utilized to support the community members in need.
Thank you.
Great. Well, with that, we probably need to wrap up here. I'm also seeing a comment about how the situation has highlighted the collective strength of our ethnic community-based organizations and how inspiring that is. I totally agree. And thanks everyone on the call and your colleagues who are providing that kind of support. So a huge thank you to all of you for joining today, for your interest in this topic. It is truly this kind of work that is going to help address our striking racial ethnic disparities around COVID in the state. This is the kind of support we need to do that. So thank you all for being willing to learn about it. Thank you, Sharon and Charles, for your work on it, for sharing that with us today. We are planning to continue this webinar series monthly through at least October and November. They are generally on the third Wednesday of the month from 7:30 to 8:30. The next two are talking about building trust between clinicians and people from diverse communities, particularly. The next one on October 21 will feature colleagues from the Hanley Center for Health Leadership and topics of implicit or unconscious bias, which we all have. And then on November 18th, on the topic of vaccine hesitancy, which we know is a huge issue generally and can particularly be an issue with people new to this culture, this country, and from different backgrounds and cultures. So we have a great panel on that with a researcher from UNC who's written a lot and researched a lot on this topic, and two members of the community who have great experience talking about building trust between clinicians and community members and patients. So please go ahead and register. It's that same link for those next two as well. We encourage you to do that. We will be, again, sharing the recording of this webinar on the CDC website and the slides as well. Liana, any closing words?
Nope, I think you covered it. We'll make sure to also include in the email any handouts and links to other languages for those handouts so that folks have that all in one location.
Great. One last plug from Sharon there, dhhs.covidsocialsupport@maine.gov. Send your referrals. Watch out, Sharon. All right. Thank you again. Thanks all. Take care. Bye-bye.
Thank you.
Thank you, Charles.
Thank you so much, Sharon.